But hello, everyone. Thank you for taking the time to join us tonight for the During Potts Health Center's vaccination information session. My name is Heidi Jobson. I'm the communications officer for Temagami First Nation. We'll be running a live Q&A at the end of the webinar. So I've enabled an ask a question feature, and you should be able to see the Q&A option below where you can type your question and I'll read it out. Or alternatively, you can use the raise hand option, which lets me know that you have a question, and then I can enable your microphone and call on you to unmute yourself so that you can be heard by our guests. This meeting is being recorded and will be available on our website afterwards at TemagamiFirstNation.ca. Now, Wayne Potts, Health Services Manager, would you like to begin?
Thanks, Heidi. Yeah. Welcome everyone, and I'm going to go right into introducing our special guests here tonight. We have Dr. Cornell, who's the acting medical officer of health in the Timiskaming Health Unit, and Carrie Schubert McKay is the director of community health, and Aaron Cohen, I believe, is the vaccination coordinator. Is that correct, Aaron?
That's correct, yes.
Yeah, and so we welcome, we'd like to, we really appreciate that you were able to do this presentation, Doctor. Also on our panel, we have Chantel Davis, who is a nurse practitioner from the Nipissing, the North Bay Indigenous Hub, which is a supporting role for our health services on Bear Island. And we appreciate that Chantel is able to join us, and of course our very own May Cat is also a nurse practitioner, and she's also sitting on the panel. And of course Rachel McKee, our pandemic coordinator, who recently just started in that position. So we're starting to get ourselves organized in the sense of response and responding to the needs in our community around this pandemic. And of course, the more immediate concern and questions and wonder is, of course, the vaccine. Now, how is that going to happen, and how is that going to roll out, and also the just details about the vaccine. And again, we're honored that Dr. Cornell is able to help us navigate that one. And I'm going to hand it over to you, Doctor, and let you take it from here. And again, I appreciate your team joining us in this manner and helping us with this process. Thank you.
Great. Thanks very much, Wayne. And hi to everybody. I've been in the area for 23 years or so. So a number of you I've met over the years up at the hospital. But for those I haven't met, as Wayne said, I'm the acting medical officer of health and CEO for the Timiskaming Health Unit. I still run my family medicine practice and do work at the hospital as well. So it's certainly interesting times. So we're quite honored to be here. Certainly, Temagami First Nation is one of the partners that we're quite keen to work with, and this is a great opportunity for us to give a presentation, talk about some things, and especially answer questions and things that might be on your mind, and we're happy to be here to do so. So I'm just going to go to sharing my screen here. Hope this all works. And let's see here. Sorry. Start with that guy, and we'll just bring this up here. All right, so maybe Heidi, I'll just check with you. Can you see that? Okay. Yeah. Okay. Yeah. Perfect. So great. So thanks everybody. And some of the slides look a little busy, but that's because I do want, certainly happy to share. And if people weren't able to attend, the slides are accessible and have a lot of the information on it. So. Again, don't be scared off by the agenda. It's just a bunch of the things that we're going to be talking about. We need to do a bit of background before we get into some of the things, into specifics about vaccines, but a little bit of background, and then we'll get into the vaccine. And then we did have some questions that were circulated before. And I've thrown in some of the commonly asked questions that we get. And we'll also address some of the myths that are out there, because that's certainly, we're hearing more and more of those as well. I've got a slide of some of the resources, and then we'll touch base a little bit. And Erin is available as well to help answer questions on specifics as to the next step as well. And then we'll have the question and answer. So first of all, when I talk about vaccines, I do commonly get the question often at the end. So I put it at the beginning, is how exactly do vaccines work? And vaccines have been around for decades and decades now. And basically what we're doing with vaccines is entering a little bit of a pathogen, which can be a bacteria or a virus, into our body, which triggers our body to form this beginning of an immune response. Whenever we have something foreign enter our body, our immune system recognizes it, and once it's fought it off, we are left with what are called memory cells, which are always sleeping in the background. And if the virus or the pathogen comes back again, those memory cells recognize it, mount our defense, which kills off the infection, or just gives us mild symptoms. So the vaccines that you're familiar with are vaccines like chickenpox vaccines or the measles vaccines. Those are live vaccines that actually have a very small amount of the virus in them. But there are also many vaccines that are called inactive or dead vaccines. The tetanus or the whooping cough vaccine are two common ones for that. And then what's new with COVID is the mRNA vaccines that you'll have heard about. I do link a resource at the end. We could do a whole session on the biology lesson of how mRNA vaccines were developed, but there's a 5-minute video link at the end. But basically, instead of using the whole virus or a whole bunch of broken up pieces, the mRNA vaccines are really specific vaccines that have been designed just by using the part of the surface of the virus. So it's really quite neat technology. Why do we sometimes need a second dose? Is sometimes to give us really long immunity, we need to give a second dose to reawaken those memory cells to produce even more of them. And certainly in public health and as a family doc in front lines, what vaccines have done is amazing. It's one of the absolute key inventions that humankind has ever come up with. And it's literally saved hundreds of millions of lives over the last century. So vaccines, they rock. They do a good job. But what's interesting is as we're rolling out COVID-19, there's increasing vaccine hesitancy, and really at levels we've never seen before, which isn't unexpected. What the World Health Organization and others are concerned about is there's definitely this global infodemic. So it's a pandemic of misinformation. And so it's really important to host these sessions, to answer questions, and to try to give people as much information and facts as we can. So as a family doctor, I've been counseling on vaccines and vaccine hesitancy for about 25 years now. And I group it into three groups. Group one are the believers. Group one is like, yep, book me yesterday. I am ready. No question. I've had my questions answered. I have no questions. I believe in vaccines. I'm ready to go. Group three is a more, it's certainly more powerful is not the right word, but it's more vocal group now, especially with social media. There's a lot more mechanisms out there for disbelievers to pass on their message. And really with group three, no matter what information we provide or talk about or questions answered, they've made up their minds and they're not going to go for the vaccine. But this group two is really the group that we really want to help support. We help support obviously group three as well, but group one, so they can answer questions. But group two are hesitant people. And it's very natural to be hesitant for the COVID vaccine. It's a new vaccine. The mRNA technique is new. And it came to market as fast as anything we've ever developed before with respect to vaccines. So it's normal to have questions. It's normal to ask questions, but we really, really want to make sure that because this group is vulnerable to misinformation, that we don't want people shifting from group two to group three because of misinformation. Hopefully once questions are answered and people see other people getting vaccinated and successfully with no side effects, it'll be easier to move into group 1 for this group. And in fact, that's what the research is starting to show worldwide, is that as more and more people get vaccinated and do fine with it and it works, then they're shifting from group 2 into group 1. So we excitingly have just finished our first wave 1A vaccination program. Erin and her team over the last week, we received enough vaccine from the government to vaccinate all long-term care home residents in our district. And as expected, there was not much vaccine hesitancy in this population. The older age group has lived through polio, and their kids had measles or mumps, or severe chickenpox. And senior citizens do not need a lot of convincing because they've lived through times where we didn't have vaccine and have firsthand lived and witnessed the benefits of vaccine. So as expected, we had about 91 to 96% or so, depending on the home, vaccine uptake. So the bottom line, I think this point here, the third one here, is one of the key messages is you, me, we're all going to make our own choices, and whatever you choose is your choice with respect to accepting the COVID-19 vaccine. And we just want to really make sure that you're being informed by facts and not by misinformation as you make your choice. So if you're following what was happening in our district in the month of December, we got hit fairly hard and quickly with our second wave. So really, it's really important to say that COVID-19 is real. COVID-19 waves can hit very, very quickly. We also know that the #1 risk factor for bad outcomes related to COVID infection is age, which was why the very first vaccines went into our most vulnerable people, which are the residents of long-term care homes. And the big thing is keeping the waves as controlled as we can, so all of a sudden our hospitals and intensive care units don't get swamped, because if they do, not only are they being swamped by COVID people, there's just not beds or capacity to manage strokes and heart attacks and other things. And so then we start to see other people die when we would normally, with capacity, be able to save them. So, the other thing that we know, as 10, 11, almost 12 months into the pandemic, is that public health measures do work. So things like masking, hand washing, distancing, following public health guidance really do work. And the big one is stay home after getting tested if you're sick. Getting people tested who have viral symptoms is the only way we know that if you have COVID or not. But it's also to acknowledge that lockdowns are very hard. They're hard on you, they're hard on me, they're hard on our families, and they're very hard on the economy as well. So people talk about, lockdowns are too harmful, and it's not that they're not harmful. There are increased mental health problems, financial, etc. Those are very real secondary health outcomes from lockdowns. But we also know, and we're seeing in the province right now as our numbers come down, and from other countries, that lockdowns do work. So I'm not going to spend a lot of time on this slide. It's just a little bit of a reassurance that even though the vaccines for COVID have come faster to market than anything we've had before, there were no shortcuts taken in the vaccine approval process. It was really a unique circumstances. It was such a worldwide crisis that the whole world came together. So all those countries that were developing and doing research on vaccines did things together. So instead of phase 1 and then phase 2 and phase 3 taking 4 or 5 years, all the steps were done. Phase 1, phase 2, phase 3, they were all done, but a lot of them were able to be done at the same time instead of waiting for one step to the other. So it really did allow for an accelerated process, but not a process that took months. And the studies were done on tens of thousands of people, and it's really important to underline that there were no shortcuts, that there are still vaccines. As much as we want as many vaccines today, there are still vaccines that are in development and waiting for Health Canada approval. So just to really reassure that Canada and other countries have taken all of the steps that they would normally, they were just able to do it quickly in partnership. So as I said earlier, what's unique about the 2 COVID-19 vaccines is they are mRNA vaccines. Now, again, without getting into it too much, mRNA technology has been around for years. They've used it to develop certain medications. But the other thing I want to reassure people is that the research into creating mRNA vaccines had actually been going on for decades. And what it took was the COVID crisis and so much of the world's experts focusing on mRNA vaccines that they were able to solve the problem. So, and that's why they were able to come to market, because they had been really studied quite closely. So just a few statistics. In Ontario, as of last week, over 280,000 Ontarians had received vaccines, and there have only been to date 83 of the reactions that meet the criteria in public health for what are called APHEs, or adverse events following immunization. So that is what we are hoping. It's a very good sign. And so far in Ontario, only one of the 83 met the classification as a serious event. So as per the studies, everything is looking like the COVID vaccines are safe. But of course, there's a lot of ongoing close follow-up, both at our health unit and throughout the health units in Ontario, to watch for this closely. And even of the 83 that had reactions, almost half were the local skin reactions that you yourself may have had if you've had a vaccine. So that itchy red swelling at the arm where you got the injection. And so far, so good. We've had around 330 people vaccinated last week, and there have been no APHEs reported to us, and our partners are watching this closely with us. So all good news. So the fun part is getting into the questions. These are questions that you may be having, and again, we'll be opening up to other questions that we may not cover. So these are probably the next two slides are the 9 or 10 most common questions that we get. So can I still get infected with COVID-19 if I get the vaccine? So right now, we don't know the definitive answer, but it is possibly yes. And it's not unexpected because it's very similar to what we see with the flu shot. So for those of you who get the flu shot every year, many, many years you will not get the flu, but some years you will. But it's milder and you don't miss work and you don't end up in an emergency department or in hospital. And so what we're watching quite quickly with the COVID-19 vaccine is if people get vaccinated and they still get mild symptoms that are shown to be related to COVID, it's important that these people, that you know, that these people still could theoretically be contagious. So even if you've gotten your vaccine, even if you've gotten your second dose of vaccine, for now, we still need everybody to follow the public health measures because we don't know yet about contagiousness and if you can get COVID after the vaccine. So even if you've been vaccinated, you still need to wear your mask when you go into the stores, hand wash, distance, etc. So that leads into the next question is, will we need an annual COVID vaccine booster every year like we do with influenza? And again, the answer to that one is it's too soon to know. It's going to depend on how the virus evolves, how the virus responds and is prevented by the vaccines, and this is being very closely studied. We've already seen a significant change in the virus. You have heard of the new variants, perhaps, specifically the UK variant that we're seeing a lot of in Ontario already. So far, I'm getting ahead of myself. That's the next question. Do the vaccines work against the new variants of COVID-19? So far, most of the research has been done against the UK variant. We know where the mutations are in the UK variant and how the mRNA vaccines work. And so far, the vaccines look like they are protective, at least against the UK variant. So again, this is really, as you can imagine, being closely studied. One of the interesting things about the mRNA vaccine is the way they're made is they can be changed very quickly. So if we're seeing that the new strain of COVID is not being blocked by the vaccine, the manufacturers can actually change the vaccine quite quickly and make it work for that strain. So that's one of the exciting things about the mRNA vaccines. So another question, of course, it's natural to ask with anything new is, can the vaccine cause long-term damage like Alzheimer's or something like that? This again, absolutely is being watched closely. So far, there is absolutely no evidence at all of this. We are also reassured by decades and decades of vaccine experience and the way these vaccines are made. But I can also confirm that there are many, many worldwide studies going on looking into this exact question, but also looking at not just Alzheimer's, but a multitude of other things. So far so good, but the medical world is watching for this very closely. So one of the exciting things, as I said, is people have had their first dose this week. And so a natural question is, after you get vaccinated, how long before we know it's working? So there's been more research on the Pfizer vaccine than the Moderna vaccine so far. There was a release a couple of days ago, an update on this one. So the latest studies show that after 2 weeks, after your first dose, there's about 89% protection already. So that's very exciting. It's also very exciting when we're vaccinating the long-term care homes, because we can have seen how quickly infection can spread in the long-term care homes. So once you get the second booster, that's where the studies showed that you get 94% and above effectiveness. So the response is really quite quick, which is a good news story. So this was a big topic. This next question is, can I get the vaccine if I have allergies? If you're following the announcements once the vaccine started to be rolled out in the UK, the initial recommendation is that anybody with allergies should be careful. That actually went too far to that extreme, and what the research has clearly shown so far, and we've seen this in the field, is that if you have allergies to penicillin or other medications, if you have allergies to dust or asthma, there is no hesitation with getting the vaccine. So let's say you've even had, a life-threatening reaction to a bee sting or to penicillin. There is no reason for you not to get vaccinated. Obviously, we're careful. We've got the treatment if somebody does have a reaction. But right now, the only reason for allergies to not get vaccinated is if you had a reaction to your first dose, or if for some reason you already know that you have a reaction to one of the stabilizers or one of the other ingredients that are in vaccines. So do reach out to your nurse practitioner or family doctor if you have any questions about that one. As we're doing the rollout, the question we get is, will children be able to get the vaccine? We're expecting the mass immunizations, where we're going to be vaccinating everybody who wants it in the community, to happen more in the late spring and the summer. So there's a lot of research going on in this. We fully expect that it'll be so, but right now one vaccine has been authorized for 16 and above, and the other is for 18 and above. So we don't know for sure yet the answer to that one, but we're quite hopeful. Similarly, can pregnant and breastfeeding women get the vaccine? Again, there's a lot of hope for it to be done so. There are pregnant and breastfeeding women who have been vaccinated, and there are studies for this. But at public health, we recommend that you review this with the person, the doctor, or again, the nurse practitioner or midwife who's following you for the pregnancy, as they're also closely following the updated research. And similarly, we get questions for people, say, who have rheumatoid arthritis or Crohn's disease, and they're on medications that suppress their immune system. Can they get the vaccine? So again, our direction is to please review this with your healthcare provider. Most of you will be able to. So the issue with a lot of people on immunosuppressant medication is, will your body react to the vaccine to give you immunity if you're faced with COVID? And for many people, the answer is yes. So the natural follow-up is, if I've got diabetes, asthma, lung disease, heart disease, can I get the vaccine? And the answer is yes, absolutely. There is no reason for you not to get so. And in fact, if you have underlying illnesses like that, it's even more important that you get the vaccine and the people around you, your loved ones. So those were the top 6 questions or 10 questions or so. And again, you may have your own, and we're quite excited to always answer questions. But these are some of the next 2 slides are just addressing some of the vaccine myths that we're being asked about and seeing specifically in our community. So with vaccines, the number 1 question is always, we need reassurance that the vaccine, or in this case, the COVID-19 vaccine, cannot give us the illness. So as I mentioned earlier, no, definitely not. This is not a live vaccine. These are vaccines that are created from tiny pieces related to the surface of the virus. So no, you cannot get COVID-19 from the vaccines. A lot of nervousness, like we said earlier, that the vaccine isn't safe because shortcuts were taken during development. And again, it's natural to ask questions and make sure that you get informed, but absolutely can reassure that there were no shortcuts taken. Public health departments were debriefed on a number of steps about this and how the vaccines were approved, and all the phases of vaccine development were undertaken. One of the things we're hearing in social media locally is that you can't that not only were shortcuts taken, but specifically animal studies weren't done. And if you hear that, you can absolutely tell people that that is not true. There were absolutely animal studies done for both the Pfizer and the Moderna vaccine. They were just done around the same time as some of the other phases, as I said earlier. So this is one that's really caught our ear quite a bit because it's actually surprisingly asked, and there's, again, whether it's the power of social media or just again, people's worry about the role of government, but the vaccine has a microchip in it, so the government can track my location. And I can categorically, absolutely say that this is not true. Zero chance that this has happened. One thing to remember is most of us have cell phones, and the cell phone companies can track where we are with our cell phones. So the government I could not imagine why the government would want to duplicate what the cell phone companies are already able to access for us. But the other thing is, I cannot imagine the cost of somehow putting a microchip in a vaccine. Not that it's at all possible, but I can absolutely say that there's no chance of the microchip being in a vaccine. We've also heard some nervousness that maybe there's a microchip in the swab that we do for COVID in our nasopharynx, and that is absolutely not the case either. Other things we've heard is a question, can the vaccine make me sterile or infertile? And the absolutely no for that one as well. There's nothing in the vaccine that affects our fertility. There's really no even theoretical mechanism where that could happen. But of course, this question and others, it's part of what's closely being watched, but certainly there is absolutely zero evidence of that happening. So I can definitely reassure on that one. And then there's this one, we hear a lot of, just if you take vitamin D every day, if you take extra zinc, you won't get sick from COVID. You don't need the vaccine if you take big doses of vitamin D. And boy, as a doctor in the field, health unit, do I ever wish that it was as true as that I wish that there were just minerals or vitamins we could take, which would make a big difference against COVID-19. But unfortunately, there's absolutely no medical evidence that that's the case. So we have to be a little bit careful when people are recommending high dose vitamin D as well, because it can cause harm. But again, vitamin D, zinc, lots of other things. There's a ton of studies going on, and hopefully we'll hit on something that will be as cheap and as easy as taking extra vitamins to really protect us. So we'd be all over it if it was the case, but at the present time, unfortunately, there's no medical evidence that we can recommend something like that. So I will leave the slide up just for a second. I do want to highlight a couple of things. Again, this is the 5-minute vaccine whiteboard video that'll take you right back to high school biology or college university biology. I really want to highlight this. Also, it's about a 5-7 minute whiteboard video. This was made by our partners at Sioux Lookout First Nation Health Authority, and it's a really well done whiteboard video. So kudos to our colleagues and our friends up at Sioux Lookout. So sharing that one with you as well. Also wanted to reassure people that public health, so PHO is Public Health Ontario. So anytime that there's an adverse event related to the vaccine, the Public Health Ontario website is accessible to the public. They also break it down by health unit. So you can see if we get reported an adverse event, that is also reported, and this link can take you to see exactly what's going on at the Timiskaming Health Unit. If you're interested in vitamin D, Alberta Health Services just did an update on the literature last week. And then as always, if there are questions that are not covered today, if you think of other questions, you're hearing rumors and you really aren't sure, please reach out to Timiskaming Health Unit. We've got a website that keeps up to date on the COVID-19 section, including the vaccine. We're tracking how many people in our district have been vaccinated as well. And certainly call us, use the website, reach out to the partners. So if people want to take a screenshot of that one, that's up there. And again, reach out, the slides are available through Heidi as well. So lastly, as I said at the beginning, we're very excited to be working with our partners at DPHS and all of you. Erin is our Chief Nursing Officer and our vaccine COVID vaccine lead. So Erin and her team will be on site on Bear Island later this week for a site visit to help do as much preparation as possible before we get the vaccine. So we're ready to get it to you as soon as we can after we receive it. So we're quite excited with the partnership with DPHS and Wayne and your group and Rachel. And let's see, we said other names, a couple of Rachels in there too. And I do want to mention too, I did talk to Dr. Goddard last night. He's quite keen to help out if needed. So again, we'll leave that to Wayne and Erin and the work you do. But Steve, most of you know Steve, and he and his team are ready to be a resource if we need their help as well, which is great. It's all about partnerships. One thing that I did want to mention is there are a lot of partnerships for our Indigenous partners, both federally and provincially. So we've heard for the last couple of weeks that there's a matrix being developed for First Nations by the Ontario Ministry of Health in cooperation with federal and Indigenous partners. So we're anticipating that coming out any day now, and that will also help us decide with you if we only get, say, 50 vaccines at the beginning. Who are the most important people in your community, the highest at risk to get them vaccinated? When do we start rolling it out to First Nation members that are, say, in New Liskeard or not on reserve? So a lot of work is being done on that, both provincially and federally, and we're looking forward to getting that document as well, so we can help you work through that question. Best case scenario is we get a whole bunch of vaccine and we can just roll it out in one big or two big clinics. So as you've seen over the last week or two, what we're waiting for is a constant continuous supply of vaccine. And it's not unexpected at the beginning that we run into problems with both Pfizer and Moderna supply. But we want to be as ready with you as possible so that the last step is getting the vaccine. Once we have it, away we come to help get your families and your population vaccinated. And I know there was some sharing of a consent form, and maybe Wayne, you'll be bringing that up, or Erin can talk to it as ready as well. So, so that's my presentation. Always interested in the question and answer period. And yeah, so Wayne or Heidi, back over to you, but maybe actually just before I'll do so, Erin just popped up. Erin, anything that you'd like to add before we add it to the question and answer, please?
I think you hit all the big points. We're really looking forward to planning with Rachel and Wayne and the team. And like you said, we're just waiting for news on when we'll get vaccine, and we'll try to get it out there as soon as we can.
Great, thanks, Erin. And I said Rachel and Rachel, but of course Chantal was the other name I missed. So sorry, Chantal. So yeah, so Heidi, over to you.
Okay, Wayne, did you want to address anything, or should we get into some question and answers right now? Okay, I'm going to go ahead and read from an anonymous attendee. Hi, some folks claim that our immune system can be boosted by consuming organic and other foods, which will help prevent and fight COVID-19. Others claim that eating such foods does nothing to boost your immune system. What's the truth of the matter?
Yeah, sure. So first of all, I'm a big believer in taking care of ourselves. So whether it's eating properly, exercising, fresh air, sleeping well, all of these things we know are good for our immune system. So when our immune system is strong and better, it can absolutely help fight off any infection. But we also know that there's a lot of claims out there, and what we are wanting to make sure is that some people saying that if you take this amount of vitamin D, you will not get COVID-19. And that's what's not true. So these things that are good for us, watching the sugar in our diet, fruits, vegetables, the antioxidants that are in vitamins and vegetables, etc. Those are absolutely good for our immune system, and those are absolutely good for us. It's just we can't depend on them to prevent COVID-19 getting into our bodies. COVID-19 is a particularly infectious virus, so do all that you can, but you also need to do the public health measures like masking and hand washing and distancing, and right now, especially as we're trying to flatten the curve of the second wave, is not gathering with a lot of people that aren't in your household.
Thank you, Dr. Cornel. So I have a hand risen. Let me see. Virginia McKenzie, I'm going to allow you to talk if you want to unmute now.
Thank you very much, Heidi. Can you hear me okay?
We can, yes, go ahead.
Okay, I have a couple of questions. My questions is regarding to the 2 vaccines that are out, is that the Moderna is, where my concern is that I see that a lot of it, the vaccines aren't for children under the ages of, like Moderna, for instance, looks at the under the ages of 18, and Pfizer looks at under the ages of 16. So what happens with our children?
Yeah, so I'll remember that you have a second question. So thanks, Virginia. And before I answer, Aaron and Carrie, if you want to expand on my answer, just unmute and jump in. I'll instead of flipping it to you. So Virginia, when vaccines are developed, especially a vaccine campaign like this that was so important to get out to market as quickly as possible, vaccines are always initially studied in adults. So it's not that we don't think the vaccines are going to work in children or in pregnant women or breastfeeding women. It's just the initial studies are done in adults. And that's just, and so the first 10,000 people that got studied and got the vaccine were in adults, and it's strictly for that reason. It's just what are called sub-studies or subpopulations, like kids, like breastfeeding moms. Those are done later on once we make sure that it's safe and out onto the market for adults. So that's why, like, these studies are literally going on as we speak. We fully expect that that these will absolutely be able to be rolled out to younger age groups, but it has to be based on evidence, especially when we want to, protect pregnant women or protect our kids. We need to have the really thorough, robust studies to make sure it's safe. But what you're seeing with those differences in the age group is that the Pfizer studies were done on 16 and above. The Moderna studies were done on 18 above, which is why there's that cutoff. So we are looking forward to the studies that show that it's safe in kids, but we need them before we can vaccinate that population.
Thank you very much.
Did you want to ask your other question, Virginia?
Whoops. Yes, I do. The other question that I have is, I'm very limited as far as, these kind of things go, is that Johnson & Johnson, with their coming out with one vaccine, what are your thoughts on that?
Yeah, so there's a couple of exciting things hopefully coming, especially as we're talking about vaccinating, thousands of people as quickly as we can. And the AstraZeneca vaccine and then the Johnson & Johnson vaccine, these are more traditional vaccines like we're often used to seeing. So for a lot of them, they're one dose, but the big thing for us is they can be stored in a standard fridge. So right now, Pfizer and Moderna have to be stored in those really, really cold freezers, the -20 freezer for Moderna and the -70 freezer for the Pfizer vaccine. And that's because of some of the unique properties of mRNA vaccine. This was the stumbling block for decades, is they couldn't figure out how to make sure they were stable. And then when COVID happened, they were able to spend so much brain power to get this problem solved. So for the AstraZeneca, the Johnson & Johnson, these vaccines they tend to be more similar to other vaccines that we've seen over the years. So it's going to be hopefully a lot easier to get these vaccines to you. So for somebody who is housebound, we can vaccinate with these vaccines where you don't have to come to us. Our teams can come to you. So yeah, it's exciting. We're starting to see some good evidence, both from AstraZeneca and Johnson & Johnson. It took them a little bit longer to develop these vaccines, which again isn't unexpected. We're starting to see that the initial response is good, and then after more time, we're seeing lots of good news with them too. So AstraZeneca has just been approved in Europe, if I remember correctly. So we're anticipating hopefully some good news coming. They do have some last few steps that they need to do to prove to Canada that everything is safe and efficacious. And hopefully there's be some good news announcement shortly, because the number one thing we need right now is vaccine. And the more partners that are on board with the safety and the efficacy studies, we're ready to roll.
Thank you.
Thank you. I think Wayne wants to say something. Go ahead.
Oh, oh, that's interesting. I see my hand came up. I was, but I did have a question. There was from a resident in the 1970s during the swine flu inoculation. One resident had a reaction by feeling very ill, nausea and sore muscles, and remembers thinking they felt like they were dying. What if there is a similar reaction? So I guess that they're a little gun shy when it comes to vaccines because of the reaction they had when they got that swine flu shot. Now, how do you compare that type of vaccine with this one, Doctor?
Yeah, so I mean, and that's why I put up that slide about the adverse events. Adverse events do happen. You can have an allergic reaction to Tylenol, right? You can take Tylenol for 50 years, and then the next time you take it, you have an allergic reaction. So things do happen, for sure. Now, so for the person who's had a reaction to a vaccine before, one of the things we'd be interested in, and after that, did you have other flu shots? Did you have other vaccines? And did you have any other reactions? Because there are a very, very small number of people who react to what's in the vaccine. So not the vaccine itself, but the other things that make it a vaccine, that are stabilizers and things like that. So there are a few people who react to every vaccine, but very commonly people get a vaccine and then they get really sick a few days later. And it's very natural to assume it's from the vaccine. But we see this every year with the flu shot is, oh my gosh, I'm never getting a flu shot again. I got a flu shot, and then a week later, I was so sick. So it could be a reaction to the flu shot, but what's also really common is when we do the flu shot clinics, there's a lot of flu going around, and there's other viruses and a lot of bugs going around. So, so the person here, sure, they absolutely could have had a reaction to the swine flu vaccine, but it could have been from something else as well. So certainly with the mRNA vaccines, these are completely new vaccines. So there's zero, unless it's reaction to vaccines, period. There's nothing a past remote reaction would predict that you wouldn't be able to get or safely get the COVID vaccine.
Thank you. We have another question from Kim. She writes, oh, I think she just erased it. I'm going to go ahead and read it again. Oh, maybe Maycat answered it. Okay, so I'm going to go on to Bob. There has been a lot of controversy in the last week about the effectiveness of non-medical masks most of us are now using, especially against the new variants. It is almost impossible to obtain these masks now. Any suggestions on sourcing these N95 quality masks? I've also heard that double masking isn't good enough.
Yeah, that's so you're absolutely right. There's a lot of concern with these new variants and a lot of discussion about masks. So if we go back to August, when the health unit made a mandatory masking for our district, and at that point we said, you know what, we need behavior change, so any face covering would work. Scarves, pulling up your shirt, and then we got into 2-layer masks, and then the 3-layer mask is the double cloth mask with a filter or something in between that makes it a 3-layer mask. So of course, there's always more and more studies and information coming in. So what we know now is that the scarves and the just pulling up your shirt doesn't work that well. The studies show that the 2-layer masks work almost as well as the 3-layer masks. But what we're seeing with the new variants is they're very contagious. So where I might have been exposed to somebody and my mask worked, the amount of virus that somebody sheds if they have the new variant is even higher than the variant we're seeing right now. So you're going to see more and more about this in the next number of weeks, is being extra careful. If we're seeing a big wave come of the new variant, that we have to be extra careful with hand washing and distancing and anybody you're in contact who's sick to stay away from them. And so what we're seeing is more evidence that the little bit of a difference between a 2-ply or a 2-layer and a 3-layer becomes even more important when the virus is more contagious. So more and more, you're going to hear the recommendation of a 3-layer mask. Now, the next step from 3-layer mask is a medical or surgical mask, and then it's the N95. Certainly this works better than this, which works better than this. But the problem is there's a shortage of, there's only a certain supply of the N95s, less so now of the medical masks. So we really need to save the N95 masks for the medical community, because we also know from the studies is that the medical masks work as well as we need it in the general community. So even as a doctor working in the emergency department, what do I wear? Even if I know somebody has COVID, I'm wearing a medical mask. The only time I'm wearing an N95 mask is if I'm an anesthetist and I have to intubate somebody to put them to sleep. If I'm doing CPR and there's just a lot of stuff flying around. If I'm a surgeon, then I'm doing surgery in the mouth or in the head and neck area. It's only that level of really high levels of COVID that we need that full protection from an N95. So for those of you in the general population, like I said, I'm working in Emerge, I'm not wearing N95s. So in the community, you do not need N95 level masking. So you really want to be looking at a 3-layer mask for the general population. Say you've got really bad lung disease, or say you're on immunosuppressant medication and you have access to the medical masks, then certainly wear those as well. But certainly at the beginning, we were really conscientious to make sure we had enough medical surgical masks for the doctors and nurses and those on the front lines as well. So I hope that helps, but feel free to jump in if I didn't cover it. Oh, we got May.
I just wanted to add to that. So Patty Hayden was on a call on Friday with our group here at NAN. She said, yes, 3-layer mask as long as one should be a polypropylene. And she said, don't throw out your masks. I mean, if you can double mask, put a polypropylene under a double mask, even if it's a homemade one, that would be some good protection for you. And that just wanted to add that.
Yeah, perfect. Thanks, May. The other thing it reminded me, so there's a fair amount of study and debate going on about the double masking. And so if you do double mask, great, but just be careful how you take it on and off. And that's the concern with people who are wearing 2 masks, is that if you go to take off your first mask, which is your outer mask, and then you touch it with your hand and then rub your eye, or then take off your other mask. So just if you're doing the double masking, just be careful with that, the donning and doffing properly, so you don't get exposed on your hands or your eyes or nose or mouth as you take off the 2 masks.
Great advice. All right, now, Kim, would you like to unmute and go ahead and speak?
Hi.
Hi.
Can you hear me?
We can.
Okay. Yeah, May, I see where May did answer my question. But my question was, I am a bit hesitant because as First Nations were being prioritized to receive this vaccine because of isolation or not as good quality health services. But are there other non-Indigenous communities that are isolated and, much like First Nations are they being prioritized to receive the vaccine?
Yeah, thanks for that. It's a great topic to discuss. So the prioritization that the province has set up has been not addressing ethnicity or religion. It's really been focused on who are the most vulnerable, to having very serious outcomes. And we know that age is the number one, right? So if we watch about what's going on in the long-term care homes, it's been devastating. And so that's
Right.
why that was a lot of the time, that was the priority. But we've also seen from experience that communities that are very tightly knit, especially if they don't have easy access to medical care. So the other group that has gotten the vaccine with the long-term care home residents before anybody else were the fly-in First Nation communities up the James Bay coast and in other parts of the far north in Ontario. Because what we've seen, and we are even in the Porcupine Health Unit that we're living it right now, is if COVID gets into the community, it can spread like wildfire. And so that population is being addressed, not because they're First Indigenous necessarily, but because they're a higher risk population for a bad outcome. So it's a very natural question to ask, but right now there really isn't another scenario other than long-term care homes and high risk retirement homes. Those are the 1A priority with the fly-in First Nations. So you can see from yourselves on Bear Island is that your community wasn't in the 1A because it wasn't a fly-in. You've got access to medical care, etc. So we expect that Bear Island will be one of the next waves once we get like this matrix that I was talking about. So it really is the most vulnerable of First Nations, which were those in the First Nation, the fly-in communities, at least in Ontario and the far north. And May, I'm not sure if
Moosonee was prioritized as well, but I think those were the elders in congregated living again, because I know Waha has them in their rollout. So that might be the only. I'm not sure if you classify that as a non-Indigenous community, though. It's pretty mixed, right? So Moosonee is the only town that's not a reserve that got prioritized in 1A as well. Aaron, I have the matrix if you want to put in the chat your email. I got it from Ontario on January the 18th. So I could send you their PowerPoint.
Please, yeah, I'd love to see it.
It's not a secret. I mean, it says confidential, but they shared it with us. So
yeah, May,
you could see how you could increase your numbers if you have an outbreak or if you have other particular things that are happening in your community. So I'll send you that.
Thanks, May, for the heads up. We'd heard that there was a draft document out there, but not the final copy. So that's great for us to have an eyeball on it. So we're even more ready. So thanks for offering.
So I just wanted to mention that it's 8 o'clock now, and we were only promised you for an hour. I have 2 more questions in the queue. Could we go ahead and do that? Or I know May Cat decided that she could probably stick around for a little bit longer too. Should I go ahead and read?
Certainly, THU was prepared till 8:30, so we're here. We're good. Thanks.
Okay. So Virginia McKenzie, you're next in the lineup. You are allowed to talk.
Thank you very much, Heidi. Okay, my question is that I'm basically a fearmonger. So prior to the World Health Organization just talking about this happening in Wuhan, I was already getting masks. So the masks that I have are, believe it or not, are N97s out of the United States that are out of the mining industry. So for one mask, how many times would I be able to use that one mask?
Yeah, that's a good question. So I don't know if I'm going to have the exact answer to that one. So So N95 is what we use in Ontario and Canada, but there are other versions of N95, like an N95S that's made, and the N95 would probably fall into that, Virginia. And what it is that we're not allowed to use it in the medical world unless it's been authorized and meets the Health Canada criteria to be that level of what we call, PPE, or personal protective equipment. But in general, the other versions of the N95s, I would expect that it's the same for the N97s, because a lot of the other versions of the N95s are from the mining world, they should provide you excellent protection. But what gets tricky is we don't have the evidence necessarily to tell you how many times you can reuse it, can it be washed, etc. So Aaron, again, our public health inspectors, if Ray was on the call, what I would recommend actually for you is, if you are internet savvy, or maybe you've got, or people can help you with, is Public Health Ontario. If you go to their website, they actually have a whole section on questions like this with respect to masking, and you may very well be able to find your specific answer on N97s. I know they definitely had a section on the cousins of N95 back in the day. But again, if you don't find what you're looking for, please reach out to the health unit and we can respond to you by email or a phone call to answer that question. Because while I haven't heard specifically about the N97, it was a question we got quite a bit of in the spring.
Okay, great stuff. This question comes from an anonymous attendee. Claims have been made by some homeopathic, naturopathic, chiropractic, acupuncture, and other alternative medicine adherents and practitioners, essentially that they have treatments that are substitutes for COVID-19 vaccines. Are these claims valid?
So yeah, thanks for asking that. You could add doctors to the list too. There are doctors and who have their own beliefs as well. And people with letters after their name, people who are healthcare providers, have a lot of power, right? I mean, we ask them their opinions, and we search out information from people in the field. So we really, really, really want people to go by the facts, go by the medical evidence, not by claims. I could have come on here tonight and said that green tea is my belief is that it will prevent you from getting COVID-19. If I can't back that up with, and again, there are tons and tons of, single studies that can be pulled off, but it really, really needs to be medical quality, medical grade evidence to be able to make claims like that. I'm always leery of people who say, this is what you need, and by the way, I'll sell it to you, because obviously, they have some bias. So people have their beliefs, but the other thing, as I said on the slide, is I would be thrilled if there was something natural and relatively easy for people to obtain that would prevent you from getting COVID-19. But quite simply, I can't say it clearly enough, is there isn't. There are studies going on, but there is no medical evidence for the claims. And really, really, the light at the end of the tunnel to help us get back to normal is vaccination. There is absolutely no doubt in my mind about that.
Okay, thank you for that. This next question, I'm a little nervous about because there's no real name attached, but I'm going to allow you to talk virtual information session. You can unmute.
Hi, it's Michael Paul.
Oh.
It's just I was listening there about people getting needles there. I'm waiting here very patiently, but the one thing I'm worried about up here is I don't know how long this before we say we get the first needle there, because around the end of March, if we get the first needle there, it could be a little difficult because the ice road does not last much longer than the end of March.
Mm-hmm.
So is there like a game plan for the second one should you need it? Like I don't know if you people actually think like that, but
Yeah.
that's one of my concerns is that right now we have an ice road. When we can't use the ice road, we're going to be switching to skidoos. There's going to be a time where skidoos, then it's back to boats. And between skidoos and the boats, there's time we just can't travel. So, like, you know,
Yeah.
I wonder
So
if anybody takes that into account.
yeah, it's a great, thank you very much, Michael, for bringing that up. I will reassure you, but I'll also let Aaron answer this one as well. But it's actually one of the reasons I reached out to Dr. Goddard last night before the today's presentation, because obviously Steve has a lot of years and experience helping Bear Island. And as you said, you know, it's important for us to think about it, but you all live it, right? And when the ice road is in and out. So, so it is very, very much on our radar, especially because of what you said. You know, the Pfizer vaccine, we need to do that second shot for it to be fully effective, you know, between 21 and 42 days. The Moderna vaccine, if that's the one we're rolling out to you, we need to be able to do that booster within 28 days. So yes, it's very much on our radar. The other thing I will say is that, as May have mentioned on the chat, is the orange or the helicopter system has been what has been providing support up the James Bay coast and flying in the doses of vaccine to those communities and making sure they're available to do so, you know, 3 or 4 weeks later as well. So there's definitely a fly-in option if it came to that. But Aaron, maybe just as a nitty-gritty with respect to your team, did you want to elaborate on Mike's question as well?
Yeah, elaborating as well that it's very much at the forefront of our mind and as far as timelines go. And I think, you know, planning as much as we can before we get the vaccine will be key to getting the clinic going as soon as possible. But you're right, if timelines start to look tight, we're going to have to look at other options. But we're really at the mercy of supply. So as soon as we know more details, we'll be able to get a really good plan in place. But yeah, it's a very good point, and we're very aware of the complexities involved.
Chantel, did you want to go ahead? It looked like you have something to mention.
Yeah, I guess I just had a question just in regards to, can you hear me okay? Yeah, okay. So the North Bay Indigenous Hub, we have a few nurses that could come out and help. I'm just kind of thinking, you know, what is our role in that? Do we just show up and all the supplies and everything will be there? Or do we need to bring stuff or kind of just the logistics basically?
Yeah, it's actually one of the questions I was going to ask Carrie and Aaron after, Chantal, with you being on the line as well, is we need to make sure we've got your contact information as well, because this will definitely be a team approach. We'll be following Wayne's you know, experience and the team on Bear Island as well. Aaron, Carrie, anything else you want to add to Chantal's point, and then we can elaborate a little bit more on how we think the clinics are going to work?
Yeah, I think after a site visit this week, planning how the clinic will run, what the maximum number of immunizers is, how many clinics we might run. Are they going to be all in one go? Is there going to be a couple of small clinics? I think lots of questions we have to answer, and then from there we can get a plan in place as to who we need, how many people we need, and all those details.
Yeah, and just for those of you who may be wondering about this, we will be working with you to meet your needs, but we can, like when we went into long-term care homes, sometimes it was like a SWAT team. Our whole team went in and took care of everything. Other times it was a partnership with the home and whatever staffing and supplies, but you know, we'll make sure there's supplies, Chantal, just to answer that component of your question, with what's available in Bear Island, and if not, we'll bring the rest. We'll also be bringing iPads for consent and entry, and making sure we know when everybody needs their booster dose. We help. There's a whole system called COVAX that we'll be helping and bringing with us.
So I helped with the development of the remote vaccine. I can't remember, they call it vaccine immunity or what. whatever name they ended up calling it. But we had anticipated if you worked with a community and if you had like, you know, some support teams like Chantel and her workers. So we thought that if you were looking at vaccinators, teams of 6, you could do 1 shot every 10 minutes. So Orange turned that back and said, no, we can only do 3 in an hour. And which we thought was low, but they were considering translation because part of informed consent is being able to translate. So we're providing translators for that. But that's, I mean, I'm a nurse practitioner, so I'm thinking, okay, how long, if I'm just giving the needle and, you know, saying hello and, you know, my name is and all those other things and letting them know, you know, that it's the vaccine. And if all the paperwork was there and administration people were helping and, you know, that consent form is fairly long. If you look at the one that Heidi put on the website today, but again, you know, most people can get through that with support, right? If somebody, you know, had trouble reading it or whatever. But, you know, today in one of the northern communities, we have 6 communities being done today through Orange. And they're kind of like quite a vast geography. But in one community, I just finished talking to the nurse practitioner and they had 44 of the clients turn up and there's 30 more that are in the queue for tomorrow. It's a small community. It's that one that was evacuated because of the water, and they did them because of the priority is they may get evacuated again, right? So that was the thinking with that one. But she said there were a number of people, like the CHR was helping. There were people, you know, sort of manning security or just watching the door. And then there was a table set up with people observing to make sure there's no side effects. And they were across from each other, but 6 feet apart. It worked out really good. And then they got to have a little snack. And the only adverse effect is somebody had a low blood sugar. So they just, you know, pumped a little more Bannock into them and she was fine and went to the nursing station to get her glucose level checked. But, you know, it went pretty smooth.
Thank you, May. I'm going to go to another question. Kim.
Hello.
Hello.
This is to Dr. Cornell. Thank you for addressing the vaccine in regards to children. I'm very concerned here with our school children. They've had maybe 6-7 weeks of school in this year. So my question is, once there is a vaccine for the children, will First Nations again be a priority, just because of location or whatever?
Yeah, that's a great thought. The quick and easy answer is I don't know yet. Right now, there is a lot of work that we're doing to prepare for what's called vaccine sequencing. Is as we get vaccine, depending on how much we get, who gets it before the others, before the others, before the others. So the children in general are going to be in a, and more in a population where we're vaccinating a whole community, say in the summer or the late spring. But if there are higher risk settings, like the children in the school setting you described, there may absolutely, again, be a prioritization or a sequencing specifically for children. So we know from the studies and just living COVID that children tend not to get as sick as adults with COVID, but of course it doesn't mean they won't, or a certain child or a certain child with an underlying health condition can't have a serious outcome. But we also know from the biggest risk factor from children is actually spreading it to their grandparents or their elders or their loved one. And so it is an important population to vaccinate. So a great thought. We don't have the answer to that yet. But there very well could be thought put to that if we just based on the experience of how we're rolling out the initial doses.
Great, thank you for that. So another anonymous question, is there a significant difference between what they call anecdotal evidence and the evidence that comes from double and triple blind studies, like the evidence expressed in support of these vaccines?
Yeah, so 100%. So there's a little bit of a what we call n equals 1 phenomenon. So if your neighbor had had the COVID vaccine and had a big rash on her shoulder, say, we don't want 200 people not to get the vaccine because of one person's experience. So we know in 200,000 people that have been vaccinated so far, that there are a small handful who have had reactions. And it's important that when you hear about the one case, because we often hear about the one bad outcome, but not the 19,999 people that didn't have any other problems. So that's why we're very, very, the foundation of a lot of what we do in medicine is what you just referred to as double-blind studies. So in other words, it's studies that aren't biased by the people who are running the study. It is the strongest medical evidence to make sure what we're saying is backed up by studies, rather than just me saying it's safe, or me saying, as boy, you really should take high levels of vitamin D. We know when we studied high levels of vitamin D, is that not only did it not work, but it actually caused harm. So that's why, for some people, so that's why the foundation of so much of what we talk about and recommend is based on those sort of studies, for sure.
Thank you for that. And Virginia McKenzie has another question. You're allowed to talk.
Thank you. I guess my question is, this is my own personal, thought, is that, with the vaccine, is that I'm kind of worried about getting it because of the variants and, some of the unanswered questions. I'm also nervous about getting it because I feel that I'm really high at risk and to also, but I'm worried that if I have some kind of effect, I'd want to make sure that I could be taken care of if I do have a side effect.
Mhm.
I would feel and I'm sorry I came in midway. Maybe this information has already been shared, but I would definitely feel safer taking it in a hospital or where there is a doctor nearby with supplies. Miigwech.
Yep, thanks. So one of the things that Erin and her team are preparing for is that exact question. So we will absolutely have epinephrine and medical supplies as part of the team. So if somebody does have a serious reaction, even though those rates are really, really low, they can happen. And you need to know that you are getting the vaccine in a safe environment. So again, it was one of the things that Steve Goddard and I talked about last night and I know it's very much on Erin's radar, to make sure that the vaccine is being given in a safe environment. And May, I think you probably lived it or witnessed it with Orange. It was certainly part of their role in bringing vaccine up the coast, as there were paramedics, I think, also available during vaccination if there is an adverse reaction. So it's going to be your own individual decision. I mean, certainly if you have health risks, that if you get COVID-19, you could become very sick from, you're part of our priority population to get vaccinated, to try to help you from getting sick from COVID. Again, you may have missed a little bit. So far, the vaccines are working against the UK variant. The studies are still ongoing for the South African and the Brazil variant, but so far so good for the UK variant. And then the other thing we know with the new type of technology, the mRNA vaccines, is if something develops that isn't responsive to the vaccine, believe it or not, a new vaccine with that addressed can be developed very quickly. It also may be part of the reason why, like the flu shot, we might need a COVID booster every year, because like flu changes a little bit every year, COVID might as well. So right now, it's reassuring evidence with respect to the new variants and the vaccines' efficaciousness or how well they're working. And B, ask the questions. But Erin and her team are going to make sure that the medications and the equipment we need to make the clinic that we will bring to you be as safe as possible. Erin, did you want to elaborate on that, or yeah, go ahead.
Yeah, I would just like to, really emphasize that health and safety is our utmost priority when planning clinics, and that includes infection prevention and control practices as well. So making sure that you're protected and our staff are protected, everyone's distanced, we're washing our hands, wearing masks, and of course, yes, having the kits for adverse events following immunization. So depending on who staffs the clinic, they will be registered staff, registered nurses, nurse practitioners, maybe even a physician, and they will all be able to respond to anything that happens.
That's some great information. Thank you, everybody. Wayne, that's about it for all of the questions in the queue. Does any of our panelists have any final comments?
Well, this has been great, and thank all the participants for their questions and their involvement in this this Zoom. I mean, it's for you, and I'm glad you're able to come out and ask those questions. And again, we're so thankful to Dr. Cornell and the team from the Timiskaming Health Unit to provide us with this background information and give us that sense of the planning that goes into this and a sense of safety and a prevention plan. Part of the safe, effective prevention plan is what we're working towards with this vaccine for our community. And so this is great to hear from you guys firsthand. I know that there's always, the questions of that relationship with the Timiskaming Health Unit, and I don't think there's any doubt from the the persons that have been on this evening that's there and it's very real. And you guys are working to get this thing in place and in a good way and in a timely fashion. And I understand that we are kind of dependent on the actual availability of the vaccine at this point, and that's something that Erin and I will probably continue to talk about as we go down the month of February here. I'm hoping. I don't know if Erin, if you want to talk a little bit about, like you said, there's a next bunch of vaccine that's coming in is in another couple of weeks, and it's possible that our community could be in that, or at least part of our community could be receiving the vaccine from that batch that's coming. Could you talk a little bit about timeline, as much as you can talk about it?
Yeah, I don't really have a lot of detail, and we thought Moderna had a really steady supply, but we just heard that we're getting a 25% reduction this month. So, it's really hard to predict at this point when things are going to happen. But I think understanding the special considerations of access to your community and the priority group that Bear Island is in, I think that absolutely, the government won't have a problem with us prioritizing your community to make sure that you guys get the vaccine. And like you said, we'll work really closely together to make sure we have a really good plan in place so that as soon as the vaccine arrives, we can get out there and hold a clinic.
Okay, thank you so much. And is there any I had asked May to sit in, and thanks again, May, for your participation and your valuable experience with this already, and input here with our work in the community, just in preparedness. We're trying to be prepared as possible, and also just maintaining a good safe practices and so on. Do you have anything else you want to say, May?
No, that we've had the pleasure of having Dr. Bogosh on our our Teams calls. I think he's been on three times now. On Friday, we had a Q&A with him and Minister Patty Haydu and our leadership. And again, that's to really address some of the concerns that came up today from Bear Island, which is, what's the information and what should I believe? And, what are the side effects? So, he's so straightforward, and I think people really believe his word for sure. I mean, his medicine and his, his persona. He's quite, the vaccine king right now. So I think in some ways having that people with the credibility has really helped. So I think having you here tonight, Aaron and Glenn has been really good for the community. And it only helps that people can talk about this. I mean, we operate under the principle of informed consent, just like you do. And the more information we provide, the better it is for people then to make up their own minds about making the decision to get the vaccine. So, we're looking at our rollout for first and second shots in 31 remote communities will be April 2nd. If we could meet that, again, supply is the issue, right? That would be, so good for our communities.
And we, thanks, May, like Chantal as well, like that resource of the North Bay Indigenous Hub is just invaluable for us, and they've been coming in to help support our nursing, community nursing needs, and again, we really appreciate your participation. We touched a little bit, and I'll just finish off with this about the priority list, and I'll work closely with Aaron in that. We've already kind of touched on that. Rachel and I have been having the discussions. We do have a pandemic plan within our community health plan, and in the pandemic plan there is a kind of a rollout of like priority list. And the first one is, of course, frontline workers, which is healthcare workers, and volunteers, which is our EFR. They are one of the priorities on that list. And then the next one that's on that list is the essential service providers, which would include police, elected officials, utility workers, the school and the daycare workers. And going down that list, of course, are the person of high risk and severe fatal outcomes for the, contacting the virus, which is the 65 persons over 65 and with special health conditions, and then the healthy adults. So that's kind of what our pandemic plan kind of lists. Now we want to be, the best case scenario is that we're just going to be able to do clinics with the whole community, and but we will start with based on that priority, and again, as the there is a logical purpose around that priority, which we will be getting, communicating out to the community why that priority list is like that. And again, Rachel is working, our pandemic coordinator is working on that list in terms of listing people in those categories in alphabetical order kind of thing. So we're not, that's just a normal process when you're divvying out this kind of, providing this kind of support and health need in our community. But I don't know if there's any thoughts on that, Aaron.
Maybe Aaron, I'll just jump in, Wayne. So that's great, and it's great work that you and Rachel are doing. It's certainly, that's all the prep. The more of this prep work we can get done before, it just makes it so much, a more effective rollout. The only thing I'll mention with so what you described for Bear Island is also is a whole debate going on in the province right now. And the only one thing that we're seeing shift up is that 65 and older vulnerable population, because we're seeing more evidence, obviously, that's the group that's the highest risk for a bad outcome. So provincially, we're seeing, that group might have been here, we're seeing it start to come up to here and maybe even here. So just to maybe have that just again, we'll be nimble. It's going to depend on how much vaccine. But even, that's not just a Bear Island issue. It's what we're talking about internally, the provinces, the medical officers of health, and what we're seeing is good evidence and actually movement across Canada to bring that vulnerable population up closer to the top of the list. So we'll work on that with you together. Aaron?
Very good. Yeah. Very good. May, what are you seeing up north around that question?
So we did a whole community approach, which is again, the elders and congregated living were sort of target number one, right? But we took the teachers, the Hudson Bay manager, the clerks, whoever, the teachers, so it didn't matter. So we took non-band members as well. Again, they're at risk for COVID, and it didn't make any sense to fly them anywhere else to get a vaccine. So that has worked out well. And so they showed up, the police were in there, they showed up to get their shots, and they'll be back, to get shot number 2 as well. So I think that whole community approach worked out well, but they did prioritize the higher risk ones first, because they had set appointments up for them, and then other people later. And then if people couldn't get to the clinic, then we had paramedics as well, so they went to the homes and gave the shots in the it's a little colder up north too, so it was easier for the paramedic to get the clothes on and the PPE and go to the house, so that worked out well.
Very good. Yeah, and this is really helpful. Thank you for your feedback on this one, because in the pandemic plan, in our community health plan, it's very generic. Like, it doesn't say what kind of pandemic. It doesn't list the different types of pandemics. So it's a kind of a general priority list. But I think you're right, Doctor. The most vulnerable, being our persons over 65 and with serious health conditions, especially, they definitely should be moved up on that list, as a high risk, because of the high risk and around this particular pandemic. Yeah, very good.
Maybe Heidi, I'll just jump in for our end. We were really excited to be invited tonight. It's a partnership that we're very keen to not only maintain but improve and grow together. And to meet May and then Chantal, Rachel, Wayne, yourself, it was a very worthwhile evening for us, and we love hearing what people are thinking and helping address questions. It's certainly part of one of the important roles that we have with this process. So thanks for the invitation, and great evening, and yeah, thanks for having us.
Thank you, Doctor, for taking that time to come and join us on this.
Great.
And thank you, Carrie, for setting all that up. and of course, our host, Heidi, applause goes to you, Heidi. Wonderful communications person for the TFN community.
Yeah, great job. And miigwech to you, Wayne, and Rachel and Heidi too, for reaching out and coordinating and making it happen. We're, like Dr. Corneal said, it's a great partnership effort, and we're really looking forward. I know Aaron's team is really looking forward to connecting and keeping this going as well with the community.
Okay, on that note, I think we're going to wrap up. I'm going to let you all leave, and remember that if you do want to refer any of your fellow community members to this, you'll be able to find it on the website under the COVID-19 page. And I hope you all have a nice night.
Aaron, I didn't get your email, so I can't send you that PowerPoint.
I'll connect you with her.
Okay.
Okay, great.
I'll introduce you.
All right.
Looking forward to it.
Miigwech, everyone.
Bye now.
Thanks, May.
Thank you.